when we have in front of us a potential patient candidate to receive this BCMA-targeted therapy, of course, we have to consider the eligibility criteria, and in principle, patients have to be, I would say, 3 drug class at least exposed and maybe even refractory. We have to consider that the optimal time for thinking in this cell therapy, and we have to consider the possibility of referring the patient for this BCMA-targeted therapy when the progressive or refractory disease is suspected for a potential candidate. We have to consider the disease morbidity as well as a risk assessment. And in principle, patients with extramedullary disease as well as patients with high-risk features can be also candidates to these different approaches. If we consider the chronological age of the patients, in principle, there is not any cutoff age for bispecific CAR-Ts or antibody-drug conjugated. But it's true that in the clinical trials, the median age for the patients included in the clinical trials with CAR-Ts is a bit inferior in comparison with bispecific, and this could be a key aspect that can help us to identify patients for receiving CAR-Ts versus bispecifics. And concerning the disease morbidity also is very important to consider the aggressiveness of the disease, because we know that BCMA CAR-T cells requires approximately 5-6 weeks in the manufacturing processes once the lymphodepletion is done until the patient is admitted for receiving the lymphodepletion. So sometimes we have to consider that if the aggressiveness of the disease is very relevant, patients sometimes can't wait this manufacturing time, and in this situation, I think that the bispecific monoclonal antibodies would be better because they are off-the-shelf drugs that basically don't require this manufacturing process. Together with these disease-based factors and patient-based factors that can potentially help us to identify the right choice for each patient, we have to consider also the organ function, and renal function can also help us because for bispecific and CAR-Ts, patients have to present with a normal renal function, and maybe patients with some degree of renal impairment can be candidates to antibody drug conjugated. Unfortunately, we don't have any information yet about other special situations like plasma cell leukemia or myeloma with CNS involvement, but maybe we will have data in the future. And finally, I think that we have to consider also the familiar and social support, because CAR-T cells requires the support from the family, because many patients have to travel from home to another center in which the CAR-T cell is going to be delivered, while the antibody drug conjugated or the bispecific monoclonal antibodies do not require from this familiar and social support. And finally, also one important consideration is the quality of life. And CAR-T cells so far have reported an excellent quality of life for the patients, because this is just a single infusion, and today it is not required from maintenance therapy, and this is clearly to impacting the quality of life of the patients. So in summary, I would say that we have to consider patient and disease-based characteristics in order to select the appropriate cell therapy for each patient.